Assalamu alaikum wa rahmatullahi wa barakatuh. This is Mohamed Sheteiwy, lecturer of general surgery. Today we will discuss the topic of peritonitis and set two examples of acute generalized peritonitis and another example of localized peritonitis. So what is the peritoneum? It is a serous membrane lining the abdominal cavity, like any lining of the pericardial sac. For example, the lining of the pleural space by the pleura is in a similar fashion to the peritoneum, and it is composed of two layers: an outer fibrous layer, which gives it the strength, and an inner mesothelial layer, which secretes the lubricating fluid responsible for the lubricating function of the peritoneum. And this peritoneum is divided into two bits or two parts: parietal and visceral peritoneum, as we will discuss later on. And the space between these two parts is a potential space named the peritoneal cavity. This space is completely closed in males, but in females it is connected to the outside through the uterine tubes, uterus, and vagina. Parts of the peritoneum, as we have said before, it is divided into two parts: parietal peritoneum, which lines the inner surface of the abdominal cavity, under surface of diaphragm and pelvic wall. So this is the parietal part. It is loosely attached, innervated by somatic nerves, so it is pain sensitive. It is painful. When irritation or inflammation approaches this part, it becomes painful and the patient feels severe pain. But the second part is the visceral peritoneum, which envelopes almost all the abdominal viscera, firmly adherent to it and cannot be stripped out from it. And it is not sensitive to pain. It is only sensitive to, it is innervated by autonomic nervous system, and it is only sensitive to stretch and ischemia. Therefore, if you have a patient with burst abdomen, for example, and his intestine is protruded through the abdominal incision or through the abdominal wound, if you catch the intestine, if you tear it with a knife or anything, he doesn't feel any pain. But if you touch the parietal peritoneum, the patient will feel severe pain. This slide is illustrating the different arrangement of the parietal and the visceral peritoneum. If you are following my cursor now, this part is the parietal peritoneum. This parietal peritoneum lines the abdominal wall, the pelvis, and the posterior abdominal wall. This is the parietal peritoneum. It is pain sensitive, but this part, which I am pointing at now, illustrating the visceral peritoneum over the liver, now over the stomach, and over the transverse colon, and then it splits to cover almost all of the small intestine. So this is the visceral peritoneum, which is not pain sensitive but stretch and ischemia sensitive. A brief physiology about the peritoneum. The peritoneum has a very wide surface area that's equal to the surface area of the skin, which is about 2 square meters. And it has the property of bidirectional spread of substances. This means it can absorb and secrete fluid from the peritoneal space. And this is the idea or the principle of using the peritoneum in peritoneal dialysis in patients with chronic renal failure. And this mesothelial, the inner mesothelial layer of the peritoneum lining the peritoneum, is very rapidly regenerating, allowing the peritoneum to heal in almost 24 hours after any breach or cut done into the peritoneum. Why this is important? Because this wide space or surface area of absorption can absorb, as long as fluid can also absorb toxins and bacteria, and is responsible for the rapid development of septic shock in patients with acute generalized peritonitis. So what is peritonitis, or what is acute peritonitis? It is defined as the inflammation of this parietal and serosal layer of the peritoneum due to the presence of either a chemical-like substance, for example acid from the perforated DU, or bile from a perforated gallbladder, or due to super added bacterial infection of the peritoneal fluid, because the peritoneal cavity is normally sterile. As in any inflammation, when we discuss the etiology of this inflammation, we have to know the causative organism, the responsible organism for this type of inflammation, and how they get infecting this part, the route of spread or the method of spreading this type of infection, how it get this bacteria or this responsible organism reaches this part and causes this type of inflammation. For acute peritonitis, it is usually secondary peritonitis. The main causing organism is usually Escherichia coli, E. coli, strep enterops may be responsible. And there is minor percentage of patients, almost about 1%. They have what is known as primary peritonitis. We can't find any documented source of infection, like bowel perforation or pelvic infection, and it is seen mainly in Egypt in patients with liver cirrhosis and ascites, and it is usually discussed by our medical colleagues or in the internal medicine department, and it is known as spontaneous bacterial peritonitis. And in a small subset, as you can see, and as we have discussed this in the anatomy of the female peritoneal cavity is connected to the exterior, and it rarely causes spread of infection through the fallopian tube, can cause some sort of primary peritonitis. But of course, this is very rare. So now we come to the route of infection. As in any infection, it mainly spreads locally or through direct infection into the peritoneal cavity, or blood spread or lymphatic spread. First of all, the commonest source of infection is the local spread. The local spread can come from any inflamed organ in the peritoneum, for example, acute appendicitis, acute diverticulitis, or perforation of any part of this GIT complicating this infection, for example, perforated DU or perforated typhoid ulcer, or post-operative after any form of operation, for example, after resection, anastomosis, and failure of this of healing of this anastomosis leads to disruption of the anastomotic line and leakage of intestinal content into the peritoneal cavity, leading to acute peritonitis. Or it can, as we have mentioned before, ascending from the female genital tract, and it is through the fallopian tube, but this is a very rare entity, and it is seen only in females. Infection can be direct through penetrating wounds of the abdominal cavity. It can be through the blood from a distant septicemic focus, or it can be from lymphatic spread from adjacent structures such as the pylora with infection, pylorizy, leading to sympathetic acute peritonitis. But this is rare. The commonest cause or the commonest source of infection is the local spread through an inflamed. There are two distinctive pathological types of acute peritonitis. The infection can become either localized in one part or in one site of the peritoneum, or becomes generalized all over the peritoneal cavity. And there are certain anatomical factors that favor localization of infection in acute peritonitis. And that's why I am putting this slide again. As you can see here, the peritoneal cavity, or this potential space, is divided into two parts. The greater sac, which is the major part, including the liver, almost to the small bowel, and this part which I am passing through with my pointer, and a smaller subset of it, which is called the lesser sac, which lies behind the stomach. This space is called the lesser sac. And these two sacs are not connected except at the foramen of Winslow, as you all know. And there is another anatomical factor which favors localization of infection, or prevents the spread of infection through the whole peritoneum. It is the presence of the greater omentum. The greater omentum separates, this is the greater omentum connecting the transverse colon to the stomach. So this is the greater omentum. And as you can see, the greater sac is divided again into two parts. The supracolic compartment, which I am pointing at now above the greater omentum, and the infracolic compartment below the greater omentum. This specific anatomical arrangements helps in localizing the infection and prevents the spread of infection from one septic focus into other parts of the peritoneal cavity. So the pathological types of acute peritonitis is divided into two parts, as we have said, the localized peritonitis and the generalized. The natural factors that favor localization, as we mentioned in the previous slide, are the anatomical arrangement of the peritoneal cavity into the greater and the lesser sac, and the greater sac is furtherly divided by the greater omentum into supracolic and by the greater omentum and the transverse colon into supracolic and infracolic compartments. Also, the greater omentum acts as the policeman, as you know, as the policeman of the abdomen. So it moves and adheres to the primary focus of infection, trying to localize it and sealing the site of the perforation if there is. And the fibrinous adhesions, which is formed as a result of organization of the exudate, shuts the lesion from the peritoneal cavity. And finally, the intestinal movement, which helps to spread the infection into the whole abdominal cavity, is reflexly inhibited by this toxic paralysis, leading to immobilization or paralysis of the bowel, known as paralytic ileus, and this loss of bowel movement helps in localization of the site of peritonitis. So these are the factors that fail. But if these factors fail to localize the cause of peritonitis, as a result, this will lead to generalized diffuse peritonitis due to either high virulence of the organism or low resistance of the body of the patient. For example, patients on steroids or immunosuppressive therapy, patients with diseases compromising their immunity, like AIDS or autoimmune deficiency disease, or patients in old age, or when the peritoneum is deficient. For example, in pregnant females, especially in the last months of pregnancy, the omentum is displaced upward by the gravid uterus, or in children where the omentum is not well developed, or sudden perforation of a hollow viscus, and there is no time for these defensive mechanisms to come into action, or the persistence of the focus of infection which is not treated, leading to failure of these localizing symptoms. And finally, if we for example force the bowel to move using enema or purgatives, or feeding of the patient with acute peritonitis, this will lead to movement of the small bowel into the peritoneal cavity, helping in spreading of the infection into all parts of the peritoneum and transforming a localized peritonitis into diffuse peritonitis. And that's why enemas and purgatives are contraindicated in patients with acute peritonitis, and that's why we are the first thing to do in patients with acute peritonitis is to stop the oral feeding and butteryl tube to relieve the fluid from the stomach and the upper small intestine, helping in decreasing the mobility of this small bowel, with subsequent decrease in the spread of infection and decreasing the diffuse peritonitis or the spread of generalized peritonitis. There are certain pathological changes that occur in acute peritonitis. For example, the peritoneum loses its glistening appearance. It is glistening, and this is lost by the inflammation. It becomes edematous and red, and it contains fibrin deposits, which is responsible for later on adhesions between the bowel and the adhesions intraperitoneally. That helps to shut the infection and localize the site of infection, and in the same time can lead to consequent adhesive intestinal obstruction. The exudate, which is secreted from the mesothelial layer of the peritoneum, at first it is serous, acts to neutralize or dilute the pus or the purulent fluid, and then it fails to do so and becomes purulent, and the lobes of the gut becomes distended with fluids, and the lobes of the small bowel becomes distended with fluid and gases, and then becomes adherent to one another and to the peritis by deposition of fibrin secreted from the mesothelial layer of the peritoneum. So what is the fate of this pathological inflammation, or what is the fate of this peritonitis? Either if the virulence of the organism is low, if the immunity of the patient is good, and the localizing factors sits well, this will lead to resolution of infection and ending this set of acute peritonitis. But if the virulence is high, if localization fails, and with this wide surface area of the peritoneum, then absorption of this toxic substances will lead to toxemia, septicemia, and eventually septic shock, supervenes. The secretion of large amount of exudate can lead to dehydration and electrolyte imbalance. And the paralytic ileus is also occurs as one of the defensive mechanisms of the body to localize the site of infection at first, and then it becomes due to adhesions from the organization of the fibrinous exudate results, and this may lead to subsequent adhesive intestinal obstruction. If the localizing factors are working well, they can lead to residual abscess formation, which commonly occurs in the subpharynx, iliac, and pelvic areas. Finally, acute renal failure as a complication of septic shock or hypovolemic shock can supervene, and bronchopneumonia from spread of infection from the peritoneum into the pleural space, leading to bronchopneumonia. So this is the sequelae and complications of acute peritonitis. So what is the clinical picture of acute peritonitis? First, we start with the symptoms. The onset is usually acute in case of perforation, but it can be chronic in cases of subacute perforation and chronic perforations. Of course, symptoms of the cause, symptoms of acute appendicitis if it is the cause, history of peptic ulcer disease, of perforated gastric or duodenal ulcer is the cause, symptoms of acute appendicitis since few days if it is if perforated appendix is the cause of the acute generalized peritonitis. And then symptoms of peritonitis, which is almost identical in any case of peritonitis. Okay, what would be the most important symptom of peritonitis? Yes, pain. Pain is the most important symptom. And pain will become maximum at the site of initial pathology. For example, if it is due to perforated appendix, it will be in the right iliac fossa. If it is due to perforated duodenal ulcer, pain will be mainly in the epigastrium. and this pain is persistent and dull aching pain, and it is increased by movements and coughing. Why? Because movement and coughing leads to movement of the inflamed organ touching the parietal peritoneum, which is more pain sensitive, leading to increase in the pain. This pain may be severe and unreal. So pain is the initial and the most important symptom of acute peritonitis, and it usually signifies the site of the pain can lead us to the cause of the acute peritonitis. But other symptoms also of the GIT are present. Vomiting. At first it is reflex vomiting in origin due to irritation of the parietal peritoneum and due to severe pain. But later on, because of the paralytic ileus, as we have mentioned before, which is a defensive mechanism helping to localize the site of infection with accumulation of fluid into the small bowel and then into the duodenum and then into the stomach with subsequent vomiting, which is effortless, copious, and usually repeated. And of course, at first it will be gastric content, then it becomes bilious, and in long-standing cases with paralytic ileus, if left untreated, that the vomitus might become feculent vomiting. And then absolute constipation, where the patient doesn't pass epiphasis or flatus, which is due to, as we have mentioned, paralytic ileus. This will lead to subsequently into abdominal distension, and finally collapse due to toxemia, and fluid loss may occur if the patient is left untreated. Signs of patient with acute peritonitis. First, the temperature early. If the patient is presented early, he will have high temperature with tachycardia, but most patients present with delayed presentation with collapse and signs of septic shock, including subnormal temperature, cold, clammy extremities and forehead, sunken eyes, dry tongue and lip, very rapid 3D irregular pulse, pale, drawn and anxious faces, which is known as you can see in this picture, which is known as toxic faces or Hippocratic faces, which is characteristic in patients with acute peritonitis. And if you see a patient like this, it doesn't need a medical doctor to know that this patient is collapsing and dying. So it is seen in patients with terminal acute peritonitis if left untreated. As you know, signs and the local examination is composed of 4 parts. Inspection. By inspection, the patient lies still. The patient tries not to move and flexes his thigh to relieve the tension on the abdominal muscle. And as part of respiration, with movement of the abdominal cavity, this can elicit pain, so there is diminished or absent abdominal respiratory movements. By palpation, the most important item seen is tenderness, and this tenderness is at first at the primary focus and then becomes generalized when acute peritonitis spreads into the whole abdominal cavity or the whole peritoneal cavity. Rebound tenderness can also be elicited, especially in cases of acute appendicitis, and the rigidity is a reliable sign that is seen in acute peritonitis, and the patient tries to protect himself from this stimulus or from the pain elicited by examination by doing what is known as gardening. But this is not the case in acute peritonitis. And board-like rigidity is also characteristic of perforated peptic ulcer. The abdomen becomes very hard, or the abdominal muscles becomes very contracted like a board, a woody board, and it is very characteristic in perforated peptic ulcer. Rigidity may be masked in aged patients, in obese patients, or in post-operative cases where the patient tries to protect himself from the pain elicited by examination by doing what is known as gardening. But there are various clinical skills that you can do to abolish the effect of gardening and to know that this rigidity is actual and reliable. Then we go to percussion. The abdomen is resonant and tympanic because the intestine is filled with gas and fluid. And there is diminished liver dullness in cases of perforated gut because of the presence of air above or under the diaphragm, above the liver. And finally, if there is copious amount of pus and peritoneal exudate in the peritoneal cavity, shifting dullness can be elicited, as in cases of ascites. Then we go to auscultation, and of course the abdominal, there is paralytic ileus with diminished or even absent intestinal sound. And don't forget to do the PR, which may be very helpful in diagnosing the cause of acute. So what the investigations, what would we do for such a patient to diagnose him? First, we can do a CBC, yes, and it will show leukocytosis with increased infection, with increased number with increased leukocytic count, which is a character of any inflammation or any infection in the body, and it is not specific for acute peritonitis. Blood electrolytes, there will be imbalance in the blood electrolytes because of the severe vomiting, the severe hypovolemic shock from the excretion of copious amount of fluid, of exudate fluid in the peritoneum, which is irritated by its inflamed organ. Another laboratory investigation is the serum amylase. It is significant when it is more than 4 times the normal value, but it is not specific except in acute pancreatitis, which is one of the causes of acute peritonitis. If it is more than 1000, it can be diagnostic, but it is not elevated after 3 days of infection or of acute pancreatitis. So in early cases of acute pancreatitis, it can be elevated and it can be used for diagnosing acute peritonitis. Another laboratory investigations such as liver function tests, platelet count, bleeding and clotting time, prothrombin time also can be used to assess the patient in severe peritonitis, especially when these patients need surgical intervention. Radiological investigations are very important in diagnosing acute pancreatitis, and in any patient with acute pancreatitis, plain X-ray erect is very important, as we can see multiple air fluid levels, which is a result of paralytic ileus, and the cause can be manifest as air under diaphragm, which is highly suggestive of perforation of the gut. As you can see in these two plain X-rays, on the right side we can see an X-ray with air under diaphragm, which is marked by the left arrow. You can see here the copula of the diaphragm on the right side is higher than that on the left side, and there is a rim of air or of air below the diaphragm and above the shadow of the liver. And on the X-ray on the other side we can see multiple air fluid levels, indicating the presence of either intestinal obstruction or paralytic ileus. We don't know. Other radiological investigations that might be helpful in diagnosing acute peritonitis. As you know, in a set of acute peritonitis, there is fluid accumulated into the peritoneal space. And yes, the best investigation to detect the fluid in the peritoneal cavity is the ultrasonography. It is easy, cheap, widely available, and it can reveal the presence of free fluid, and ultrasound-guided aspiration or paracentesis can reveal the pus, indicating the presence of acute peritonitis. And if ultrasonography cannot diagnose the cause, we can use a CT scan with IV and enteral dyes, which can confirm the cause of acute pancreatitis, or can be also helpful to exclude causes like acute pancreatitis, as the treatment is essentially conservative in cases of acute pancreatitis. CT scan also can diagnose the presence of bowel ischemia, gangrene, perforation, internal hernias. It can detect the amount of pus or fluid in the peritoneal cavity. And when these modalities fail to diagnose acute pancreatitis, laparoscopy can be used, and it can be both diagnostic for detecting the cause, and it can handle or treat the condition. For example, in duodenal ulcer perforation, you can do a mental patch repair using laparoscopy, or if a cause cannot be found and the condition is considered the primary peritonitis, with laparoscopy you can do peritoneal wash and drainage of this infected peritoneal fluid. The principles of treatment mainly depends on controlling the source of infection. This is the most important cause. This is the most important item in treatment. You have to remove the source of infection, or perforation or whatsoever causing this acute peritonitis, and you have to remove the bacteria and the septic fluid which is present in the peritoneum. This is in line with maintaining vital organ functions, cardiac, pulmonary, and renal functions, especially in the ICU setting, with maintaining nutrition and metabolic support for these patients. Treatment is divided into two main categories. Patients who will need conservative treatment, who are the few patients of this acute pancreatitis, and many patients will require resuscitation and urgent laparotomy. And this is done in the setting of three items. We have to do preoperative preparation of this patient through mainly three items: ryle, cannula, and catheter. You put the ryle in the patient to deflate the stomach and bowel and prevent vomiting during induction of anesthesia, to relieve the distension and improve the paralytic ileus. You put a cannula to give intravenous fluid to correct the hypovolemia, resuscitate the patient, maintain hemodynamic stability, restore hemodynamic stability, and maintain renal blood flow. And this is done usually, as I told you, in the ICU setting. And antibiotics can be given. We start with third generation cephalosporins or quinolones, and then according to culture and sensitivity testing. And you shouldn't wait for the culture and sensitivity testing. You should start with empirical antibiotics and then change your antibiotic regimens according to the results of culture and sensitivity. Analgesics should be given to the patient at this point to improve the survival. You shouldn't leave your patient in pain, especially if you have already diagnosed the cause of acute pancreatitis, the cause of acute peritonitis, and further investigation will not be carried out. The patient is taken to the theater. And finally, Foley's catheter is very important to check the urine output, adjust your fluid replacement, and ensure there is adequate renal blood flow. After good preoperative preparation, when the patient is hemodynamically stable, then you can take your patient to the theater for performing the operation, and the operation will be exploratory laparotomy. And what do you think the incision which would be useful for exploratory laparotomy? Yes, a midline incision. The incision might depend on the site of the primary focus, but it is usually midline incision is employed because it is rapid, gives good access, and it can deal with either right or left-sided pathologies. Some old authors say that paramedian incision can be used because most of the causes of acute peritonitis mainly lie on the right side, but midline incision is now the rule, and it is used in most of cases of exploratory laparotomy. Upon incising the abdomen, you will face copious amounts of peritoneal exudate, and this exudate can help you to identify the source of the perforation, of the source of infection. For example, it is a bile-stained fluid. This means it is a perforated DU. It is brownish feculent fluid. It is from a perforated appendix or a perforated diverticulosis or diverticular abscess. Then after that, this is a photo showing the midline incision, and this is after closure with what is known as tension sutures, which is used in closing the abdomen in patients with acute peritonitis, because healing and because infection rates are very high, and the subsequent dehiscence and burst abdomen can occur. So tension sutures are used to ensure adequate closure of the peritoneal cavity. So now we have, and when you open this is a photo which is seen when you open the abdominal cavity, copious amount of pus is usually seen, aspiration of this pus and the drainage is usually carried out. After incision and drainage of the peritoneal fluid, which drainage of the infected peritoneal fluid which is present in the peritoneum, we manage the cause. And this is different according to the cause. If there is bowel perforation, you should close the perforation. If there is intestinal obstruction, you should do resection and anastomosis at the site of the obstruction. If there is appendicitis, you can do appendectomy. And for that, this is a picture of perforated U. As you can see, the stomach is pulled with a Babcock forceps, and you can see a perforation is seen here in the a perforation is seen here. Okay, this is the site of the perforation, a duodenal perforation. This is the stomach which is pulled outside the wound. This is another set of causes of acute peritonitis. As you can see, there is perforation of the small bowel in this, and the bowel is completely covered with biogenic membrane, what is known as biogenic membrane. This is another perforation, another ileal perforation, and there is biogenic membranes all over the small bowel. Then, after managing the cause, you have to do proper peritoneal toilet. Some surgeons advise the use of antibiotic saturated saline for cleaning the peritoneum, but this is not usually available, so you have to remove as much as you can all of the exudate and the infected peritoneal fluid. And finally, drainage tubes are used to ensure that any further fluid that might be collected in the peritoneal cavity can be drained to the outside. You put one drain in the pelvis through a suprapubic step incision, because the pelvis is the most dependent part in the ups and while the patient is walking in the standing position. And you can put a Morrison drain in the Morrison pouch, because the Morrison pouch or the hepatorenal pouch is the most dependent part while the patient is lying in the recumbent or the supine position. Of course, the site of the primary focus should be drained if needed. And finally, the wound can be drained with a subcutaneous drain, because of the very high incidence of wound infection following this. Post-operative management is essentially in the ICU setting to control complication or prevent complications like respiratory infection, renal failure, DVT. Monitoring is done by regularly checking electrolytes, platelet count, liver and renal function tests, checking oxygen saturation, heart rate, blood pressure, urine output, hourly if needed, and repeating the ultrasound or chest X-ray to ensure complete removal of the septic focus, and there is no regeneration or there is no recurrence of the cause of this infection or acute peritonitis. Finally, removal of the drains. The subcutaneous drain can be removed after 2 or 3 days, and other drains can be removed when their discharge stops, usually in the 4th or the 5th post-operative. This was the methods used in treating patients who need urgent laparotomy and urgent intervention to control the source of infection. But in cases of peritonitis, for example, in primary peritonitis and in cases of salpingitis, provided that your diagnosis is certain and the general condition of the patient is good, conservative treatment can be used in these conditions, and it follows the same lines as those of Ochsner-Sherin regimen used in treatment of appendicular mass. Also, we can do percutaneous ultrasound guided drainage or CT guided drainage by placing a drain into the collections or into the peritoneal fluid to drain it and control this condition, and it can also be used in patients who are unstable and severely ill and are present in the ICU with very high mortality rate. Drainage can be helpful until the condition is improved and the hemodynamic instability is corrected and restored, and the stability is restored again, and these patients can be taken later on to the theater if they survive. All of the previous conditions were examples of acute generalized peritonitis. What happens if the general condition of the patient is good, if the localizing factors are working well, this will lead to localization of either resolution of infection completely or localization of infection to one part of the body, leading to what is known as intraperitoneal abscesses. And we will discuss two examples of intraperitoneal abscesses: the subphrenic abscess and the pelvic abscess. In subphrenic abscess, there is accumulation of infected fluid in relation to the undersurface of diaphragm. Usually, this is caused by localization of diffuse peritonitis in the subphrenic space. And then, each space has its causes. And the spaces are usually 4 intraperitoneal spaces and 3 extraperitoneal spaces. The spaces are illustrated in this space, and you can imagine the causes for abscess formation in each space. So as we have said before, we have 4 intraperitoneal spaces termed 1, 2, 3, and 4. The first space is the right anterior intraperitoneal space in front of the liver, and usually it is caused by perforated gallbladder, acute cholecystitis, perforated DU. The second space is the left anterior intraperitoneal space, and this space also occurs as or abscess here occurs following surgeries of the stomach, the pancreas, the spleen, the left lobe of the liver, and so on. And then the other posterior spaces 3 and 4 are well known. The number 3, which is the left posterior intraperitoneal space, it is also known as the lesser sac. This space, fluid can collect here mainly following pancreatic surgeries, following inflammation of the pancreas in the form of pancreatic pseudocyst. And the fourth space, which is the right posterior intraperitoneal space, which is known also as the hepatorenal space or the Morrison pouch, which is where collection or pus collection can occur following any abdominal surgery, because it is the most dependent part in the recumbent position, and again after infection or after inflammation or perforation of the appendix, the gallbladder, kidney. All these can lead to accumulation of fluid in the Morrison pouch or in the hepatorenal space or the fourth space. Then we have 3 extraperitoneal spaces, right and left perinephric spaces, and infection usually occurs following hematoma or trauma to this area. And the last space is the bare area of the liver, where collection occurs after perforation of an amoebic or pyogenic liver abscess. So these are the important spaces, anatomical spaces, where pus can collect, and they are all known as the subphrenic spaces. The clinical picture of a patient with subphrenic abscess is characteristic. There is hectic fever with sweating and wasting, and anorexia is usually present, and hiccup due to diaphragmatic irritation, and the pain may be referred to the shoulder on the affected side. The signs: usually the patient has high temperature, is feverish with tachycardia and toxic facies, and locally, as we have said in generalized peritonitis, there will be also impaired respiratory movement and tenderness over the lower ribs just below the costal margin, and there will be also upper abdominal rigidity or swelling might be seen by local examination, but this is not the case in every case of subphrenic abscess. Subphrenic abscess is usually difficult to diagnose, and when you are suspecting there is pus somewhere, there is pus somewhere in the body, the patient has hectic fever, the patient is toxic, has leukocytosis, is tachycardic, the patient is in septicemia and might pass into septic shock, but you can't find the source of the pus. There is pus nowhere, means you can't find the source of infection, you can't find the source of this severe toxemia and septicemia. Then you should suspect that the pus is usually might be under the diaphragm. So pus somewhere, you have pus somewhere in the abdomen, you could find it. Nowhere, you pass nowhere, you couldn't find this pus. So it is usually pus under the diaphragm. It is usually a subphrenic abscess. Investigation done if you are suspecting or in case of a subphrenic abscess. Yes, blood count with leukocytosis, but again it is non-specific. It can be raised in any form of inflammation. X-ray might be helpful. It can show you elevated copula of the diaphragm. It can show gas under diaphragm with a fluid level. There might be obliteration of the costopheretic angle due to sympathetic pleural effusion from the pus below the diaphragm. And finally, ultrasonography and CT. And CT is the most important diagnostic modality used in subphrenic abscess. Treatment. Conservative treatment with using Oshner-Sherin regimen might be employed, but interventional treatment is usually needed to drain the pus. And this drainage should be done ultrasound guided or CT guided using special catheters. And if this drainage fails, or if this interventional drainage fails, the pus recollectus or the abscess is multiloculated, then surgical drainage is needed, and extraserous drainage should be employed. This means that you don't want to contaminate the whole peritoneum, because the abscess cavity is a localized cavity, and you want to do it to do drainage for it without contaminating the rest of the clean peritoneal space. So you have, according to the site of your abscess, if it is located anteriorly, you do anterior extraperitoneal approach. The abscess, if the abscess is located anteriorly, and if the abscess is located posteriorly, you can do a posterior subpellural approach through the bed of the 12th rib, where the rib is removed, and then you open the abscess cavity without contaminating the normal clean peritoneum around the abdomen, inside the abdomen. Another example of localized abscesses in the peritoneal cavity is the pelvic abscess. The pelvic abscess means accumulation of infected fluid in the pelvis, in the rectovesical pouch in male, or in the Douglas pouch in females. Etiology is similar to the subphrenic abscess, either due to localization of diffuse peritonitis into the pelvis, or due to infection or inflammation of one of the pelvic organs, for example, a pelvic appendicitis or acute salpingitis. The clinical picture of pelvic abscess is similar also again to the clinical picture of subphrenic abscess. You have history of the cause, you have specific symptoms here. There was a hiccup, but here there is diarrhea and passage of mucus in the stool, which is the most characteristic symptoms due to irritation of the rectum and the sigmoid colon by the presence of pus. So this leads to passage of mucus in stools and diarrhea. Signs: there is tenderness in the suprapubic region, and if you do a PR or pelvic examination, a PV, you can feel the presence of tense and the tender cystic mass. Investigations are similar: blood count with leukocytosis, ultrasonography and CT scan is the most important diagnostic modality. Treatment, again, conservative treatment using Oshner-Sherin regimens, and interventional treatment if there is fluid collection or pus collection with closed drainage, either ultrasound or CT guided drainage, and surgical drainage also with extraserous drainage. And as you know, if the abscess is present in a male, if a pelvic abscess in a male, you can do posterior proctotomy if pointing into the rectum, and if it is in a female, you can do a posterior colpotomy. You can drain the abscess through the posterior vaginal wall, which lies in vicinity of the collection or of the abscess in the Douglas pouch. If the abscess is pointing above the pubis, you can do drainage through a suprapubic route, but also following the rules of extraserous drainage to prevent contaminating the clean peritoneum other than this area of localization. One of the examples of acute peritonitis is the perforated duodenal ulcer. As you know, the duodenal ulcer has, or chronic duodenal ulcer has, many complications, either acute or chronic. Acute complications include bleeding and perforation, and the chronic complications include obstruction and malignant transformation in gastric ulcers. And we will discuss here the one of the acute complications, which is the perforation of the duodenal ulcer, which is a very common complication of the duodenal ulcer and might be the first presentation of peptic ulcer disease in almost 1/3 of the patients. Perforation of the duodenal ulcer can occur in either one of three presentations, either acute perforation with acute DU or acute perforated DU, or can lead to subacute perforated duodenal ulcer, or chronic perforation, which is known as the penetrating ulcer with subsequent fistula formation. So how a duodenal ulcer gets perforated? Usually the patients, and some patients, or in most of the patients, they have a history of peptic ulcer disease, although almost 1/3 of them might not have this history of previous ulcer, peptic ulcer disease. When an exacerbation occurs due to many factors, work, worry, change in the weather, the use of ulcerogenic drug, spicy meals, all of this will increase the intragastric pressure, such as following a heavy meal or straining. This may lead to perforation of an inflamed peptic or duodenal or gastric ulcer or peptic ulcer disease. And I usually like to memorize it as a medical student with too many worries who eats a heavy meal at Kentucky with a lot of spicy food, leading to perforation of a pre-existing peptic ulcer. Usually duodenal ulcer perforates more than gastric ulcer, or tends to perforate more than gastric ulcer. Why this occurs? Yes, because the duodenum has a less stronger wall than the gastric ulcer, so it tends to perforate more easily, and it tends to perforate more commonly than the gastric ulcer. And of course, because the duodenal ulcer is by far more common than the gastric ulcer, so the perforation occurs more commonly in the duodenal ulcer. When perforation occurs, it passes through three distinct stages. The first stage, when perforation occurs with the escape of the irritant gastroduodenal contents into the peritoneal cavity, leading to chemical irritation of the peritoneum with subsequent chemical peritonitis. Septic peritonitis doesn't occur yet, and the patient has severe pain, which may lead to neurogenic shock. So the shock in the first stage is usually due to severe pain, and it is the type is neurogenic shock. Then, when the peritoneum reacts to this chemical irritation, it secretes copious amount of peritoneal fluid to dilute these chemical substances, leading to relief of the pain for a short time. So it is called the stage of reaction. It lasts for a few hours, and it depends on the general resistance of the patient and the site of the perforation, being longer in duodenal ulcer than the gastric ulcer, because usually DUs have a smaller size of perforation and the content is becoming less irritant as it is being neutralized by the biliary content of the duodenum. But the gastric content is usually more acidic and more irritant, and gastric ulcers usually bigger than duodenal ulcer with subsequent release or escape of more of acidic irritant material into the peritoneum. Sometimes the content may pass through the paracolic gutter to the right iliac fossa, where gastric ulcer perforates directly into the general peritoneal cavity. Finally, the third stage, the patient passes into septic peritonitis. This occurs when the body resistance fails and the microorganisms invade the peritoneal cavity and pus forms with subsequent absorption of toxic substances into the circulation, with toxemia, paralytic ileus, dehydration due to the secretion of large amounts of fluid into the peritoneal cavity, with subsequent septic shock, SIRS, and finally death may occur from multi-organ dysfunction syndromes. What are the complications of perforated duodenal ulcer? Yes, they are the complications of septic shock. Septic shock in these patients is usually the cause of death, and toxemia, fluid electrolyte imbalance, paralytic ileus, acute renal failure, acute respiratory distress syndrome, multi-organ dysfunctions, all of these can lead to death from perforated duodenal ulcer as a consequence or as a result of the septic shock that occurs as a terminal event in peptic ulcer perforation. This patients usually, or this disease usually affects middle-aged males because they are more prone to DU and more prone to stress, ulcerogenic drugs, smoking, spirits, spicy food. All of this leads to exacerbation of a pre-existing ulcer disease. But this is not the case in all patients. Some patients might present with perforation as their first presentation of their peptic ulcer disease. The patient usually comes in severe pain in the epigastrium, and this pain might be referred to the shoulder, vomiting once or twice, and the patient may pass into shock. And as we discussed before in the pathological types, if the patient is presented early, just a couple of hours after the onset of pain, the shock is usually a neurogenic shock. But if the patient is presented later on, the type of shock will be in the form of septic shock. By examination, generally signs of shock: subnormal temperature, tachycardia, tachypnea, reduced urinary output, and blah 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 blah. Okay, by local examination, by inspection, also again similar to what we have mentioned or discussed in acute peritonitis, there will be decrease or little abdominal movement with respiration. The patient lies still because any slight movement increases the pain. By palpation, there is tenderness, which is maximum of the perigastrium or begins in the epigastrium and then spreads all over the abdomen. And there is a character of rigidity. It's called board-like rigidity. It is characteristically seen in perforated duodenal ulcer disease. Percussion: when we perform a percussion, the liver dullness is usually obliterated by the presence of air under the diaphragm, and if the amount of fluid is huge in the pelvis, shifting dullness can be elicited in the flanks if there is moderate to marked amount of free fluid in the peritoneal cavity. By auscultation, intestinal sound are absent due to the presence of paralytic ileus, which is one of the defense, which is early as a defense mechanism to prevent the spread of microorganisms, and later on it becomes due to toxemia. What are the investigations that can we do in a patient presented with acute abdomen, pain mainly in the epigastrium, history of peptic ulcer disease, and I have great concerns that this patient might have a perforated duodenal ulcer from the history and the examination? First, we do laboratory investigations. Yes, CBC will show marked increase in the leukocytic count. Again, amylase will be increased due to secondary absorption from the peritoneal cavity. But of course, it doesn't reach the levels of pancreatitis or the diagnostic levels of acute pancreatitis. Blood gas and electrolytes can also be useful to determine the state of shock, and the correction of these electrolyte deficits and gas abnormalities and the blood gases abnormalities should be done in the ICU settings before the operation. The main radiological investigation is plain X-ray abdomen in the erect position, because it will show the copula of the diaphragm with air under the diaphragm. But again, this doesn't exclude the absence of air under diaphragm, doesn't exclude the presence of perforated viscous or perforated duodenal ulcer, as maybe 30% of cases will not have this air under diaphragm. If the patient is in grave condition and cannot stand, X-ray can be taken in the left lateral position to show the air under diaphragm. At this point, it is usually sufficient to take your patient to the OR to do your operation or to do your exploratory laparotomy and managing the site of the perforation if the diagnosis is adequate with air under diaphragm. But the problem arises when you cannot see the air under the diaphragm in that 30% of patient. Then you can use a dye study that is injected as gastrographene meal into the stomach, can show the escape of the radio-opaque medium through the perforation. Again, if there is fluid into the peritoneal cavity, then ultrasonography will be very useful to detect the presence of this free fluid. Of course, ultrasonography cannot detect the perforation or the cause of the fluid in many times, but it is a useful indicator, or it is a useful investigation in detecting the presence of this free fluid and aspiration of this fluid, which yields bilious fluid in the early stages and pus in the later stages if the patient is presented late. And if after all of these diagnostic tools, CT scan remains the very sensitive investigation whenever there is absence of gas under the diaphragm, and of course it is more useful in ruling out other conditions like pancreatitis. So what is the differential diagnosis of a case of acute perforated duodenal ulcer? We have two distinct important items that we should differentiate any patient from them. First, patients with acute abdominal pain. Perforated duodenal ulcer is one of the main causes of acute abdomen, and in many times, especially if there is no air under the diaphragm, differentiation between the causes might be difficult. And this is very important as the management differs according to the cause of the acute abdomen. Another dilemma arises in patients who have air under diaphragm. If you have a patient with abdominal X-ray with air under diaphragm, there are various differential diagnoses that you should exclude in this patient. Of course, if the patient is coming with acute abdomen with air under diaphragm, this equals the presence of perforated viscous, which is usually a perforated duodenal ulcer, although there are other viscous or there are other abdominal organs that can perforate and present with air under diaphragm, as we will mention later on in the next slides. The first thing we should differentiate is from other causes of acute abdomen. First, acute appendicitis. History can differentiate pain around the umbilicus that's shifted to the right iliac fossa. Then the pain becomes, when the complication arises of acute appendicitis, the pain becomes generalized, but usually history of pain that is shifted to the right iliac fossa is prominent in cases of acute appendicitis. Usually with perforated, even with perforated appendix, there is usually no air under the diaphragm and the patient is presented with acute abdomen. CT abdomen with contrast is usually can usually differentiate between the two conditions, although in some cases with trickling of the fluid in paracolic gutter and presentation with pain in the right iliac fossa, this can be very difficult to differentiate, and some conflict can arise and patients might be operated as acute appendicitis while they are having a perforated duodenal ulcer which has leaked through the paracolic gutter with minimal free fluid, with minimal air under the diaphragm, differentiation can be very and sometimes very difficult, although CT is usually sufficient to differentiate between the two conditions. Acute pancreatitis, as we have said, it has a similar pattern of pain, but the pain usually is referred to the back. The pancreatic pain usually refers to the back. The vomiting is much more severe. There is more abdominal distension and rapid deterioration of the general condition of the patient. Amylase is markedly elevated, more than the levels in perforated duodenal ulcer, but CT usually can differentiate or can exclude the presence of acute pancreatitis. Acute cholecystitis also may have a similar clinical picture, with ultrasound very useful in diagnosing acute cholecystitis, and again there will be no air under the diaphragm except if perforation of the gallbladder occurs, and in such a case CT might be very useful if you are suspecting CT. Also again can differentiate between the two organisms. Other causes of acute abdomen, like ruptured aortic aneurysm, the patient usually comes with hypovolemic shock, rapid deterioration of the patient within 1 hour, and it is usually a fatal condition. Myocardial infarction, the presence of chest pain should be diagnosed. The presence of chest pain with ECG and cardiac enzymes can also exclude the presence of myocardial infarction. Mesenteric ischemia is one of the difficult things to differentiate, but there is no air under the diaphragm except when perforation of the bowel occurs. The pain is usually very severe from the beginning, and CT also can exclude the presence of mesenteric ischemia. Finally, pneumonia, basal pneumonia, can lead to upper right abdominal pain, and diminished breath sounds in the lung, on the affected lung, can also exclude the presence of pneumonia for the space. As you can see, this is multiple modalities, plain chest X-ray and CT. The white arrows show the presence in this one. The white arrows show the presence of that this is the area of air under diaphragm. Again, this is the area of air under diaphragm, and just behind the abdominal wall. Also, this is in the sagittal section. We can see a huge area of air under diaphragm in front of the liver and below the diaphragm. In front and above the liver, this is the liver, in front and above the liver, and below the diaphragm. Also, we should differentiate this condition from any patient who is having an X-ray with air under diaphragm. Does any patient who has an X-ray with air under diaphragm signifies the presence of ruptured viscus? Of course not. There are other causes, and this is a very common question, frequently asked in your Viva exams. So you should know this causes of air under diaphragm very well. First and the most common cause of air under diaphragm is postoperative. After any operation, either laparotomy or laparoscopy, the presence of air under diaphragm might occur, and it might remain. If you do an X-ray for this patient after even 1 or 2 weeks, you still find the presence of air under diaphragm. The second commonest cause is ruptured viscus, especially a perforated U, which is the commonest cause, followed by typhoid ulcer as the second cause. Perforated gallbladder and perforated cancer colon or perforated colonic diverticular comes next, but they might not be presented by air under diaphragm, and even perforated appendix cannot be presented, or is usually not presented by air under diaphragm. The third cause of air under diaphragm is the presence of intra-abdominal sepsis by gas-forming organism, which leads to formation of air, and air floats upward above the liver and below the diaphragm. And an old test that was done by the gynecologist, it's called the tubal insufflation test, done for cases of infertility in females, also can leads insufflation, means ballooning of the tubes to see if there is any strictures or adhesions or any obstruction to the passage of the ova. and this, as you know, the tubes are connected into the peritoneal cavity. So after performing this insufflation test, air leaks through the tubes into the peritoneum and floats into the above the diaphragm, above the liver, below the diaphragm, leading to air under diaphragm. So the commonest causes post-operative any rupture viscus, especially perforated due intra-abdominal sepsis by gas-forming organism, and the gynecological tubal insufflation test done for infertility. Treatment follows the rules of acute peritonitis. First, we have to deal with the septic focus, remove the peritoneal exudate, manage the cause of the perforation or manage the cause of this acute peritonitis, and finally drainage of the abdomen and putting drains and removing. So first we start with resuscitation of the patient by giving him Ryle tubing, antibiotics, starting 2 wide bore cannulas and starting fluid resuscitation. Analgesics can be given at this stage after complete diagnosis of the patient, and urinary catheterization to monitor the urine output and to monitor your the adequacy of your fluid resuscitation. And after adequate resuscitation, the patient is taken urgently to the theater for urgent surgical intervention. And according to the general condition, also again this follows the rules. We do midline exploratory laparotomy, and then we take an abscess of the, a swab or a sample of the peritoneal exudate for culture and sensitivity test. Then we deal with the cause accordingly. As we know, this is followed by drainage of the peritoneal toilet and putting your drains, and finally closure of your wound, and then following up the patient. The specific management for this condition depends upon the general condition of the patient. If the patient has a bad general condition, for example, in a case bad general condition, for a case of gastric ulcer, we should take a biopsy, a 4-quadrant biopsy from the edges of the ulcer to exclude the presence of underlying malignancy, because it's quite common to see a perforated gastric cancer and the patient will be presented by perforated gastric ulcer. So you have to take a biopsy to exclude the presence of ulcer. The ulcer is closed in 2 layers, inner through and outer seromuscular layer over a patch of omentum. And in case of duodenal ulcer, we do what is known as Graham operation. It is based upon the same defense mechanism the body does. The body tries to localize the site of the infection and control the sepsis and the perforation by migration of the peritoneum, the policeman of the abdomen, to this part or to this perforation, and that's what's exactly done in Graham operation, as we take an omental flap or an omental patch and we suture it, or we suture the perforation over this flap. You can see in this photograph, we take 3 pre-taken sutures at the base of the ulcer, trying to go away from the inflamed and fibrosed part. Then a patch of omentum is placed over this part, and your ties or your sutures are tied over this omentum. This is a live photo showing the site of the perforation, as you can see, which is marked by my pointer hand. Then 3 pre-taken sutures were taken from the edges of the ulcer, from the healthy parts of the edges of the ulcer. Then an omental patch is put, and then your sutures will be tied over this patch, terminating this operation. Luckily, this is what is done in almost 99% of cases of perforated duodenal ulcer, because the patients usually present lately in bad general condition, and in almost more than 50% of cases this is usually enough, and the patient doesn't need any further intervention. But in case of good general condition, definitive ulcer surgery might be performed. In case of gastric ulcer, you can do partial gastrectomy, and in case of duodenal ulcer, you do a truncal vagotomy with a pyloroplasty as a drainage procedure. Of course, this should be combined in both general and bad condition with good peritoneal toilet and good drainage, as we have said before. Another entity or another presentation of the perforation of the peptic ulcer is the subacute perforation. When it is subacutely perforated, it leads to leakage of minimal amount of fluid due to the gradual erosion of the ulcer, and the body reaction tries to localize this leakage or to localize this infection according to the mechanisms we have mentioned before, so leading to the formation of a perigastric abscess in case of gastric ulcer perforation, subacute gastric ulcer perforation, or the formation of a subphrenic abscess in case of a perforated or a minimal subacute perforated duodenal ulcer. Presented. How is the patient is going to be presented with subacute perforated peptic ulcer? There is usually history of peptic ulcer disease. Then the patient develops attacks of pain. The pain usually starts in the epigastrium, then becomes in the right iliac fossa due to the trickling in the paracolic gutter, as we have mentioned before, and this can be differentiated from acute appendicitis or pain following complicated appendicitis, because the pain starts around the umbilicus, then becomes in the right epigastrium. There is of course hectic fevers. All of the other presentations of subphrenic abscess, including hectic fever, toxic facies, and in abdominal examination there is rigidity and tenderness, usually localized to the right hemi-abdomen because of the presence of the abscess. The treatment is the drainage of the abscess, and then this drainage can be carried out either ultrasound guided, CT guided, and if this fails, a surgical extraserous drainage might be needed to relieve this abscess, and this is followed by definitive treatment of the ulcer. If it is a DU, then vagotomy and pyloroplasty. If it is a third complication of perforation of peptic ulcer is the chronic perforation with forming a fistula to a nearby organ, which might be the pancreas, the liver, or the transverse colon, and the clinical picture is mainly due to the change is mainly presented by the change in the character of already known peptic ulcer pain. The pain becomes continuous, not related to meals, and antacids no more relieves this pain. And if the pancreas is penetrated, the pain will be radiating to the back and relieved by leaning forward. And if the colon is penetrated, a gastrocolic fistula results with fecal vomiting, fecal eructation, and severe diarrhea due to irritation and contamination of the jejunum and the duodenum by the highly irritant colonic bacteria. The treatment of such a perforated ulcer is usually separation of the ulcer with partial gastrectomy and staged colonic resection to treat the presence of cologastric fistula. Thank you. I hope you enjoyed this lecture, and see you later. Assalamu alaikum.